event. Today we have several agenda as follows: plenary talks, oral presentation session, break, and invited speaker session. Before we open today's event, I would like to read today's ground rules for all of the participants. Number 1, participants have to make sure that the microphone is mute unless speaking as the presenter or invited to speak by the moderator. Number 2, participants need to make sure that they have enough bandwidth to participate in the conference. Number 3, all participants are not allowed to take any picture or recording of presentations in this conference. Number 4, all participants have to use their full name without the title on the account used in accordance with the name during registration. Number 5, each speaker is given 30 minutes to present. There will be a gentle reminder from the moderator to help speaker keep up with the allocated time. Number 6, Q&A session for 7 minutes will be conducted at the end of each presentation. Number 7, participants can deliver their questions by writing down the question in the chat box or click the raise hand feature. Right now, we will have a photo session first. So for all of the participants, don't forget to open your camera and turn on your Zoom video. And also use the virtual background that is provided by the committee. For the participants, please get ready. I will count down to 3. 1. Okay, it looks like the participants still get ready. Okay, I will count to 3. 1, 2, 3. Okay, and then we will retake once again. Okay, 1, 2, 3. Okay, thank you so much for the participants. I would like to inform all of the participants that there will be a link for attendance in the chat box. So for all of the participants, don't forget to fill in the attendance form. Okay, there you go. Before we move on to the plenary talk session, I will introduce today's plenary talks moderator.
Once again, I would like to welcome our distinguished speaker, invited guests, participants, and also the committee to the second day of the 7th International Conference on Pharmacy and Advanced Pharmaceutical Science ICPAPS 2021 and the 12th Annual Conference of the Indonesian Society for Cancer Chemoprevention ISCC 2021. Thank you to the committee for the nice opportunity for me here. I'm Vivi Kurniawati. It's an honor for me to be the moderator for today's plenary session. This today's plenary session will consist of two parts, 30-minute presentation, followed by around 7 minutes Q&A for each speaker just after each presentation. To all participants, we welcome you. If there are any questions, please drop your question on the Q&A box, and we will address them later just after the presentation finishes. Now, let's begin with our first speaker. Welcome to Prof. Sean Hsiang Yin Shen from the, hopefully I'm not mistaken on the pronunciation, Prof, sorry. Okay, let's welcome Prof. Sean Hsiang Shen. Morning, Prof. Xiang Chen. How are you today?
Very good. Thank you for having me, and I really appreciate this opportunity. Yes.
Before you start your presentation, let me briefly read the background of Prof. Xiang Chen.
Thank you.
Okay, Prof. Xiang Chen received PharmD training from University of Iowa. She served as the pharmacy director of TMU Wanfang Medical Center for 12 years and the associate dean TMU Office of the Global Engagement for 4 years. She is now a professor and associate dean for the education TMU College of Pharmacy. Dr. Chen's current research is directed toward optimizing the medication use and pharmacy service in clinical settings. To the best use of medication, her research team has been studying on the pharmacoepidemiology, pharmacogenomics, and pharmacovigilance for adverse drug reaction. To develop the best pharmacovigilance, the best pharmacy service, the team published many articles on pediatric medication error prevention, formulary management, and cost containment, medication reconciliation, human resource development, pharmacy informatics, and clinical pharmacy service project for documenting the value of pharmacies. Okay, this is the background of Prof. Sean Chen. Hopefully I'm not mistaken in mention your name, Prof. If there's mistake, I would like to apologize first. Without further ado, let's welcome Prof. Sean Chen to deliver his presentation.
Right. Thank you. Yeah, thank you for Dr. Fifi's kind introduction. So I would like to start today's presentation. And firstly, I would like to share my screen. Should I do that, or the organizing committee will do for me? I think I can do it right now. Does everyone see my screen right now?
Yes, it's clear.
Okay. All right, thank you. So today my topic of presentation is extending pharmacy products by new technology. And my name is Sean, so Dr. Fifi pronounced wonderfully. So everyone call me Dr. Sean, so that's easy, okay? So it's not able to move. Okay, and my outline today, I will follow the 4 parts. First of all, I will present some, maybe everyone knows about a lot of new technology happened today in medical field, in medical products. And then I would like to briefly introduce you about medication management, and which is the most important part for pharmacist work. Then I would like to shift the topic to big data analysis, especially its use, its application on medication management. And I give you my small perspective. Okay, so let's look at the new technology application in nowadays medical products. And I hope maybe you have seen this movie before, Big Hero. If you did not, you may try to watch it over the weekend. And in this movie, it showed a very pretty nice AI doctor, and not only AI doctor, also a very nice caregiver, and which is Baymax, this very cute, very big robot. So it has been many years ago when I first saw this movie. So that means our publics do have this kind of dream and have this expectation that one day we can have a very nice personal AI doctor with us. And when you have any kind of disease, by watching you, the AI doctor knows how to take care of you. So this is a dream we as an AI robot doctor. And now there are many things can be diagnosed. Many diseases can be diagnosed by artificial intelligence, AI. So by applying the technique of deep learning, now the AI can actually read MRI for diagnose cancer more precisely and more quickly than human being. And also many applications such as optimal coherence tomography, OCT, for differentiation different eye diseases. And then electroencephalography, EEG, reading those patterns of your EEG. The AI doctor can give a very nice suggestion about the type of a seizure or any kind of brain disease. So, and there are many diagnostic algorithms can be applied can be diagnosed by deep learning technique. And also some companies try very hard to provide treatment algorithm. Like IBM, they have a small section like called Watson for oncology. And they develop an AI doctor like called clinical AlphaGo. And you know, AlphaGo is a very famous robots that actually work much better than human being. So, and this clinical AlphaGo, they actually combine taking the data and the results from textbooks, journals, and many internal documents or some data from medical centers. So they provide online service to provide medical advice to clinicians. But it does not work very well, still far away from our expectation. But there are many successful examples, other examples like using AI medical robots, or having this one, UCLA, they have a robot doctor to perform ICU run. And this one you can actually check on YouTube. They all have different videos. And this ICU EVA, that robot called EVA, and can run much faster than a real doctor. And when patient has some emergency, the EVA can go there at the first moment, and then quickly screening the patient's situation and provide a suggestion for care. And other things like advanced AI robots, they help for surgical operations such as Da Vinci. So in TMU at our university, Taipei Medical University, our 3 hospitals, all of the many surgeries actually performed by Da Vinci, the advanced AI robots. And AI also help for genomic. Nowadays, there are whole genome sequencing techniques. So well, we are able to see many genomic data, but they are too much and difficult to interpret. So AI can actually help to identify the risk genes for diseases. So this is a very interesting story, like the Angelina effect. And it actually happened in 2013. And a movie star called Angelina, by AI prediction, she found she has 87% of a probability to have a breast cancer in the future. So she decided to have a surgery right away. So to decrease her probability to have breast cancer. So of course, people are very astounded by this action. So it goes to a time on the cover page. And then some other thing like new drug discovery. And by using those technique for big data analysis, this is one I call AtomNet technology. And by this, we can actually develop a lead compound faster, much faster than traditional experimental way. So then I would like to move to our next section. So our topic today is about how to apply those new technologies in in clinical pharmacy. So we want to look at the principle of medication management and how to apply new technology on that. So I think the core knowledge, our domain knowledge for pharmacists is how to keep medication safety. And of course, the most important task is to find out what things that we have to implement and how to improve the quality of each steps of the medication management cycle. So the first step is the formulary management, and as require clinical knowledge to compare medications within the same pharmacology class, and based on the clinical guidelines, and you select the most suitable medications for your hospital or your institution or your country's formulary. And then by then, have a good storage. So that's the first step. And this formulary management usually require physician, nurse, pharmacists to make decisions together, but pharmacist is of course the leader of a formulary management team. And then next one is reconciliation. And every time when you have a new prescription coming, you have to reconcile the patient's medication. And then after a right reconciliation, we go next step, and which is the physician to prescribe the prescription. And then pharmacists have to verify the prescription. If there is any drug-related problems, we have to connect to the physician and request for a change in the prescription. And then we dispense. Then the next step is administration. So inpatient medication is actually dispensed to nurse and require nurses to do administer. And if that's for outpatient, we give the medication directly to the patient, and the patient is the person to administer the medication to themselves. So therefore, we have to provide medication education to patients And also we have to provide to nurse or to physician and other healthcare providers. Then finally, we monitor the drug response. Also, the whole team, including the patient, have to complete this work together. And then while doing the whole process of medication management, there are chances to have medication error. And the error could happen to while choose a medication or write a prescription or manufacture or dispense or administer. So there are many steps, many possibilities to have medication errors. And when we run this process of medication or prescribing and administration, the cycle, there are different professionals to help the process. So we hope when we look at the cheese features, that's possible. Those errors be blocked between different healthcare providers. But there are also possibilities that no one have found it and the error reach the patient. So we have to do many things, and new technologies can help our clinical pharmacists to do those medication management cycle much better and much efficient. So giving an example of prescribing. While physicians do prescribing, pharmacists can do many things to help physicians to better prescribe their medications. So I'd like to give you some story that in year 2000, in Taiwan, most of the hospitals starting to work on labs, including TMU's healthcare system. And we are the only one of the two hospitals to develop the most early computerized medication safety system. So we put in our prescribing system with lots of alarms, alarm function, including drug allergy, cross allergy, maxima, single daily dose, or pregnancy formulation information, and random dosage adjustment, duplicating drugs, drug interaction, indication, appropriateness of the drug use. So there are many ways that we can help our prescribing much better. And one is the screen show as an example of the drug-drug interaction. And I'm sorry that you could not read Mandarin, but you can see in here you have a 1 and a 2. That means the two drugs prescribed together, and then because there is a drug-drug interaction, so we have those information system on our backbone, and then the screen pop on to alarm the physician. There is a drug interaction, and you could not prescribe them together. So please cancel one of your medication. And this is another screen about pregnancy category blocking. And if the patient actually has a pregnancy check and starting to have their schedule for mental care, the system has that information. And while the patient may go to see any other care advisor and then have a new prescription, and if the medication is not suitable for pregnant woman, the screen also pop on and remind, oh, this is the category C and this is category X, and you may want to design another medication for the patient. And this is another system for inpatient. And inpatient medication, you know that we have many IV medications, injectable drugs, and they are requiring lots of knowledge to help correct administration. So we actually put many information data in the backbone. So if you prescribe a certain medication, we require, while the prescriber select those diluent, for example, normal saline or any D5W dextrose, and there is if there is an incompatibility issue, the screen will not allow them to process. So, and also they have to enter the route, and the route is actually preset, and only those routes that's suitable for that certain medication can be entered. And there are publications of mine while doing the medication safety informatics. Our team published many articles, and we compare with and without this information system, how we avoid those medication errors and how the efficiency demonstrated. So there are publications for pediatric dose checking system, renal dosing checking system, allergy checking system, and also some patient education online system, and some learning for student learning as well. And we do medication reconciliation for a central data bank, and also nursing home, how we connect a hospital with our nursing home for medication reconciliation. And you are welcome to check my publications, and they are very easy to check by PubMed. And then we look at those verification dispense process. And this is also very important for having our pharmacists to have more time to do direct patient care. For example, discuss with the patient about their medication, or join the team to help decision-making. These are very important and the art of nowadays clinical pharmacy practice. So we have to decrease the time that we need to pay on dispensing. So counting pill is a very simple thing, and actually knowledge can help us. So traditional way, just like that, everyone sit on a table and checking and do those counting. And the other way is now we have auto dispense machine, and in that machine, it connected directly with our CPOE, computerized physician order entry system. And it can actually dispense those medication very fast. And this machine that we have at almost 20 years, and all of our hospital has that. And you can put about 500 medications inside, and then they can count the pill and put in a very nice bag for patients. So it actually helps pharmacists to do their work. And inside of that, while we put the medication into each small closet, we have to use the barcode system to verify that we put the right medication into the right place. And then while checking the prescription, our pharmacists just need to screen the prescription and then look at those screen. And for all of those medication safety alarms that we send to physician, it also shows on our pharmacist screen. So pharmacists can look at whether or not physician accept the system's suggestion and how they change. So it will be a very useful system for us to save our dispense time, but increase the time for pharmacists to do cognitive service to verify the orders, verify the prescriptions. And there are much more dispensing system. And this one is inpatient automation. And and I took from Swisstock, and you may actually reference to their system. So there are many different automation systems, and I believe each place, each hospital can gradually to select what is the most suitable automation machine for pharmacists. And this is one of the systems that we use in our hospital, like auto dispense cabinet, ADC. And for those state medications, we actually don't require a pharmacist to do that work one by one. We can have those medication in this auto dispense machine. And while nurse want to take those state emergent medications, they can enter and then the prescription after pharmacists verify checking, it can be taken. And physician, those you can see the video that the two nurses, they are checking together, and then they enter the patient's number and then confirm. And then they select the prescription, and then they verify the number of medications, and then confirm. And then the box pop out, and only the place with the right medication open. So they can only take that medication in the closet. And because the system records every medication there, so we can actually very easily to find out if there any mistake happen during taking the medication. So in our TMUH, our university hospital, we put less machine in all of our medical wards. So we have 22 medical wards. Each medical wards have that. So we still have our regular drug cart to go from the central pharmacy to the nurse to the wards. But between the time for our medical cart go to the medical ward, if there is any emergency, need to take so-called state medications, we use this ADC, the automatic dispensing cabinet. And for education, there are many ways that we can provide patient healthcare medications. So this is a very old function that we have for many years. And every patient can see on the website to find out their medications, and they show all of the color, the shape, and the outlook of the medication, and also some informations. But now we also go ahead to do more than that. We provide the medication information by social media, and we do randomized controlled trial, and this has been revised currently by JMIR. And reconciliation, and I hope this actually require many work, and you can check the JCI definition of a medication reconciliation. That means that at every transition of a care, when the new medication are ordered, you have to check the patient has the current medication the patient has, and in order to avoid omission or duplication or dosing error or drug inactions. So in Taiwan in 2013, the government has a Taiwan pharmacology system. So all the medications prescribed to the patient through hospital or clinics or dispensed by pharmacy go to the pharmacology database. And we have 2 methods to check, but only physician and the pharmacist can read the patient's past 1 month medications. So it will be very on time for pharmacist or physician to check the patient's every prescriptions. When the patient comes to you, you can check their previous medication and decide whether or not you need to prescribe the medication to a patient to avoid duplication, interaction, such as that. And some similar function also developed by other countries. For example, this is Australia system for controlled drug substance. They all connected because controlled substance is extremely important. And this is a prescription drug monitor program that's a state-run in United States, also for controlled drugs, controlled substance. So now I'd like to shift to big data analysis for clinical pharmacy. And we know that pharmacovigilance is very important, and that's the art and the activities for understanding and prevention of adverse drug reaction. And pharmacoepidemiology is also very important that help us to understand the medication use pattern and risk factor for ADR. Actually, WHO has its own pharmacovigilance system. It combines data from different countries and the different years. And by that, the WHO Collaborating Center, which is located in Sweden, Uppsala from ADR Center, they can actually find out a new ADR or new drug interaction, and then make a suggestion for dose adjustment or contraindication and so on. So in my lab, we're trying to connect the medication management cycle with a skill for pharmacoepidemiology and pharmacogenomics. And we do those data, such as hospital data. We use our 3 hospitals data or the reimbursement data from Taiwan National Insurance Bureau or other data in the future. And we're trying to connect with our partners in United States. And anyhow, currently we do statistical model or machine learning model and trying different new techniques. And this year we are challenging for deep learning, and then to apply our on the echo model or identification of our issue of study, and also predict the outcome of pharmacotherapy. So this is one paper that we published in 2020, and this one we use machine learning to predict hepatotoxicity. And this one includes genomic data and clinical data. So from my perspective for our new technology application in clinical products that actually save pharmacists time, increase our efficiency, and able to predict and prevent adverse drug reaction or adverse drug events, and optimize medication use. So collaboration is important, especially in multidisciplinary or working with a computer science person. That's very important for us to strengthen our pharmacists' ability by new technologies. So by that, I would like to thank for your listening. And if you have any question, I would like to answer now. Thank you.
Thank you, Dr. Shan, for the nice presentation. Okay, for the question, I will read down from the chat box. Wait, let me see. There's several questions about the presentation. Okay, for the first question from Bapak Amal Reza Putra, he asks about how to do the validation on the automatic dispensing equipment in Taiwan.
Okay, the question is about
The validation, how to validate the automatic dispensing equipment.
Oh, how to validate the auto dispense equipment. And for example, for that big machine that I show on the screen, that now is actually every hospital, every big hospitals, and also some community pharmacy, if they have a service for nursing home, their prescription amount is quite big. The volume of the prescription is quite big. So they also use the auto dispense machine. And why? How we validate that? We usually, I better stop the. Okay, all right. So how we do that? We usually we double check that when we pour down the pills into the machine. That you have shown, you have seen that we have each cassette we set that barcode, and we double check the barcode with the bottle that you put down. So if those barcodes are the same, it validates. And then the second way is when the medication going out, in that small sacks, we have pharmacists to see it. So pharmacists have to read those medication. And so pharmacists still need to remember those outlook of each medications. So you have to confirm it by manually by a pharmacist. So while we usually have a few steps. The first step is the machine dispense, and then pharmacists check. And then we also need to check the computer. And while checking the computer, you see those alarms, dosage or drug action, and so on. So pharmacists don't need to manually to dispense, but you have to check everything. So that's the way. And usually we have a second pharmacist to dispense to patient. So the other pharmacist dispense to a patient. And while dispense, you have to show a patient the pill. So if there is anything that machine goes wrong, we will see that as well. Yeah.
So to the validate, you use the barcode for checking the barcode, and then manually checking by the pharmacist before give to the patient, right?
That's
okay.
Right. Yes.
Thank you, Dr. San. For the next question, this is from Ibu Woro Harjaningsih, Miss Woro Harjaningsih. Thank you, Dr. San, for your good sharing. I want to know about the medication technology in Taiwan. Our hospital in Taiwan have applied the system. If it available, how the pharmacist will interact with the doctor? Is it a collaboration with a pharmacist and doctor to ensure the patient, to ensure the right monitoring for the patient, to maintain the monitoring to the patient?
Oh yeah, thank you. This is a very good question. And usually, yes, because now we have many technology for medication dispense, and all the hospital apply the system. Yes, I think because we developed the system quite early, it's about 20 years ago, and now most hospital, because the sample size, the patient baths are big, so you have to use automation machine in some way. And if that's really small hospital, maybe they go totally by manual. But I think that's the number of hospital not using auto dispense machine are very small. And what I see is even some community pharmacy, they use auto dispense machine as well. And how pharmacists interact with the doctor? Yes, we usually, if we found the prescription need to optimize, we call the doctor right away. Because now you don't need to spend so many time to dispense. You have time to call doctor. And explain to them and ask for a change for the medication. So it is one way that you call them. And the other way is if you are a clinical pharmacist in patient base, we go round with doctor because while doing medical rounds, you can directly advise a physician while they probably make a wrong prescription or anything. So that's the two ways that we interact with patient. And is collaboration with the doctor still maintained for monitoring the patient? I think so, especially for those inpatient. But outpatient pharmacist, outpatient setting, it's sometimes require the patient to call us back. So we are very easy to work together with physician as well. Yeah. Okay.
Thank you, Dr. Sean, for the discussion. Very nice discussion. Because the time is already up due to the limitation of the time. So I'm sorry, I have to end the discussion for the first session. Later, you can save the question for the second speaker, maybe. Okay. Thank you, Dr. Sean. Once again, thank you. Before we end the first session, on the behalf of the committee, we will deliver the certificate of appreciation for you, Dr. Sean. Thank you. Give big round of applause to Dr. Sean. Thank you very much for the new insight and very interesting presentation. This is a promising new technology to improve our role of pharmacists to optimize the patient medication. It's very promising and become our challenge to do the predicting what the unpredicted for this ADR. Sorry for the interruption. Once again, Dr. Sean, thank you very much, and hopefully we can see you again in the future. Thank you.
Thank you for the organizing committee. Bye-bye.
Okay, bye-bye. Thank you, Dr. Sean. Okay, without further more, let's continue to our second speaker, Associate Professor Dr. Hashniza. Is Dr. Hashniza Zamanhuri already in the room?
Yes, I am.
Okay,
hello, Miss Phoebe.
Hello.
Hello, how are you?
Dr. Hashniza. Okay, thank you for joining us with us today. Okay.
Thank you very much.
Okay, good morning, Dr. Hashniza.
Morning. Assalamualaikum. How are you?
Waalaikumsalam. Fine. I'm fine. Hopefully you are fine and healthy too today.
Alhamdulillah.
Okay.
Thank you so much.
Thank you. Thank you for having us today. Before you start the presentation, I would like to introduce you. We'll read the background of Dr. Hashniza Zamanhuri.
Thank you.
Dr. Hashniza is an associate professor of clinical pharmacy and pharmacogenomics in the Department of Clinical Pharmacy and Pharmacy Practice, University Malaya, Malaysia. She is the founder dean of the Faculty of Pharmacy. It's a newly established at the 13th faculty in the University Malaya since September 1st, 2019. She has published more than 70 paper indexes in the world of science in her area of expertise. She held various critical administrative posts. Among others is the Manager of Clinical Investigation Center, CIC, from 2012 to 2015, and later appointed as the Director of Head of the CIC, 2015 to 2019. Under her tenure, CIC won many accolades at the international levels, procured around 590 clinical trials, and work with 300 pharmaceutical sponsors and CRO worldwide. At the present, she is also the honorary visiting consultant at the CIC and the permanent member of the Drug Control Authority, DCA, Ministry of Health, Malaysia. This is the brief background of our second speaker, Dr. Hashniza Zamanhuri. Without further ado, I would like to invite Dr. Hashniza to deliver her presentation. You have about 30 minutes of presentation. I hope it's enough, maybe. Then we later continue to the Q&A or the discussion session. Thank you. Please welcome Dr. Hashniza Zamanhuri.
Thank you very much, Miss Phoebe, for the kind introduction. So thank you very much to the organizer for inviting me. So I would like to share my screen here. So can you see my screen?
Yes, doctor.
All right. Thank you very much. Okay. Okay, Assalamualaikum, good morning and hi everyone. I'm Dr. Hashniza. So first of all, I would like to thank the organizing committee for inviting me to this ICPAPS 2021. So I would like to share today for my topics, pharmaceutical care in COVID-19 for the clinical pharmacist's role in optimizing disease management. So the role of clinical pharmacists has been increasing, especially during COVID-19, yeah. Although this may look simple, but I think there's a lot of points that we as a clinical pharmacist can venture. So this is my content of presentation for today. Yeah. So I will start off with, I think everyone knows this is the current pandemic affecting worldwide, which is COVID-19, and up to now it has affected 100 millions of patient populations. It's about 245 million. And the recent figures of that is close to 5 million. Yeah. So COVID-19, as everyone knows, caused by SARS-CoV-2, yeah, severe acute respiratory syndrome, coronavirus 2, yeah. And actually we have 5 stages that I will explain in my next slides. So this is when we talk about the severity of infection, we have several stages. Mild, most of the time patients will have no or only mild pneumonia, and this encompasses for the most of the patient category, which is about 81%. And we also have severe category whereby patients have shortness of breath, yeah, dyspnea or hypoxia, and more 50% involvement of lung. And we can see that, in the imaging within 24 to 48 hours. And this encompasses is about only 14%. And we have those critical patients whereby they need respiratory failure and have septic shock, and also multi-organ dysfunction. So this is a very small patient population, is about 5%. So as for the clinical stage, just now we have 5 stages. Most of the time, category 1, as we know, there's no symptom. Category 2, symptomatic without pneumonia. And category 3, symptomatic with pneumonia. Category 4, that might require supplemental oxygen. And clinical stage 5, whereby the patients with multi-organ involvement, and we also shock. Yeah, for example, like septic shock. So when it comes to clinical pharmacists and pharmaceutical care, I think clinical pharmacist is very synonym. The pharmacist that actually responsible for the provision of the rational prescribing of drugs, and clinical pharmacist actually embraces pharmaceutical care concept. So this is the concept that I think everyone is well versed. It comes from Hepler and Strand in 1990. Basically, pharmaceutical care is the responsible provisions of medication related for the purpose of achieving definite outcomes that improve patients' quality of life. So when we talk about outcomes, so this is a very important outcome for our patients, how we as a clinical pharmacist could help our patient to improve the outcomes. So when we talk about the outcome, these are the outcomes that we are referring to We want our patients to cure from the disease. For example, patients with COVID-19, definitely we want patients to be cured from COVID-19, or elimination or reduction of a patient's symptomatology. If patients comes with symptoms, we want to alleviate the symptoms of the patient and to reduce the symptoms of the patient. And we want also to arrest or slowing the disease process. So for example, if the patient is in category 1 or 2, so we wouldn't want it to proceed to category 3, 4, or 5. Yeah? So there's a lot of intervention that we can do there. And definitely this will be our ultimate objective at the end of the day. The best is to prevent the disease or symptoms. There's a lot of things that we can do actually as a clinical pharmacist on how we can counsel the patient even on how to actually prevent the disease itself. So I will share that a little bit in my last slides here. So when we talk about how to achieve the outcomes, is mainly we have to identify the potential and actual medication-related problems. You know, there's a lot of medication-related problems that can actually hinder the patient outcomes. And after we identify, we have to resolve the medication-related problems. And, you know, this is definitely our main ultimate goal, is to prevent even it is, you know, from occurring the potential medication-related problems. So by this way, we would be able to help our patients and also to improve the quality of life. So when we talk about drug-related problems, so this is under the umbrella of pharmaceutical care. So pharmaceutical care actually look at a very big perspective, and drug-related problem is a very important component of pharmaceutical care. So most of the time, so even if we can actually take care of the drug or medication-related problem, so this will be definitely helpful for our patient. So if you can see here, there are some classifications of drug medication-related problems. I think Prof. Sean has also shared with us just now. So although you can see there is 8 classification, but this is not only exclusive for this classification. We have many more, but this is the main problems that our patients always facing. For example, like untreated indication. Yeah, for example, in patients with COVID-19, once they have hospitalized in ICU, perhaps they would need proton pump inhibitor for treatment of stress-induced ulcer. Okay, so this is one of the example whereby, you know, we have to see as a clinical pharmacist what are the indications that the patients have, but then it is not treated. And of course, improper drug selection for various categories of patients, patients with different organ function, patients with different renal function, liver function, and so on. So we have to see which particular medication is best suited for our individual patient. And subtherapeutic dosage or even overdosage is most commonly being overlooked, you know, in certain cases. So we have to see which is the right dosing for our patient. And failure to receive medication. Yeah, so this is also one of the problems, especially during COVID-19, whereby we are focusing on the management of COVID-19, but we have to see our patient is also a chronic medication, yeah, patients with chronic medication, whereby they also need other medication. So it's actually our role to ensure that there will be a proper stocking, so that, you know, we have a very good planning in terms of managing drug shortage. And of course, when we talk about ADRs and drug interactions, this will be the main issues and also problems encountered in our patient, especially concerning with COVID-19 management. There is a huge potential problems. Example, chloroquine that can cause QT prolongations, and also corticosteroids, you know, that actually, if you were to use, it can cause the respiratory distress syndromes and so on and so forth. So we have to see, you know, in case if our patient is on polypharmacy, so this could actually cause more adverse effect burdens to our patient. And of course, drug-drug interaction. So I will show you later one of the studies whereby there is quite huge potential of drug-drug interactions, especially with patients receiving COVID-19 medications. And of course, medication use without indication. So this could enhance burdens of the patient receiving the drugs and also the ADR as well as drug interactions. So when we talk about clinical pharmacies and also COVID-19, of course, this is only not restrictive to only this particular function, but there's a lot more actually, what we can do to help our patients and also to assist other healthcare providers in COVID-19. So for example, like protocol, when we actually repurpose our antiviral because there is no specific treatment indicated for COVID-19 nowadays. There's a lot more to do with symptoms and so on. So we can actually look at how we can repurpose the antivirals, and especially when our patients exist with co-infection, which is bacterial infections, co-infections. So the AMS programs, antimicrobial stewardship program will be very useful, when we want to reduce the antibiotic resistance, and how we can actually enhance the rational prescribing of antibiotics. And of course, provide medication management recommendation. So there is quite a busy day during COVID-19 with all the healthcare providers also. So we as a clinical pharmacist would want to venture more how we could actually help out patients to choose the better medications for the patient, and also to think of a possible alternative, switching to possible alternative or whatnot. So that would be one of the important role there. And of course, pharmacists, we are also being trained not only to manage the patient, but also being able to interpret the test result, for example, PCR test result, and so on and so forth. And of course, pharmacists will also explore new drugs via clinical trial, clinical research. So we are always together with the clinician, following our good clinical practice on how we could actually further explore new potential drugs for COVID-19 and also be involved with clinical trials and part of the data collection process. And of course, the role of telepharmacy, could not be denied during this era. This is, in fact, the most important one, whereby we can do a lot of things through telepharmacy, counseling, even to communicate with our healthcare providers, and also to actually coach the patients for the device counseling, so on and so forth. So there is a huge role of telepharmacy nowadays. And in fact, telepharmacy would be able to reduce our contact with patient and therefore reduce the number of cases in general. And of course, when we talk about inventory management, it's quite important for us to ensure that the stocks is sufficient and ample during this time around, so that we're not only focusing on the COVID-19 but also other management of chronic disease. And also pharmacovigilance, when we have to be more vigilant, especially on the monitoring of the ADR on the patients. There's a lot of ADR as well as drug-drug interaction that we could actually monitor. So for example, just now, chloroquine that could actually cause QT prolongation. And there's a lot more of adverse effects, so that we have to observe that in our patient. So for drug utilization evaluation, this is where we could actually, monitor and also manage each of the individual drugs in the patient and see which is the most suitable drugs to be given to patient in case we have condition, for example, like, for that particular condition, we need to rationalize and we need to see either benefit outweigh the risk. So I think the role of clinical pharmacists is quite huge for this one. And also, as everyone knows, we don't really have treatment for COVID-19. So this is the time whereby we could be together with other clinicians or healthcare providers in terms of preparing the guidelines and also treatment algorithms, in terms of the details of the regimen, the details of the ADR, DDI, and so on. And also, we could also have for the disinfection and sterilization process. We know very much, how to do this, for example, like the concentrations of the ethanol, isopropyl alcohol. So we are also well versed. So we can also be part of this to actually help out to ease the burden of COVID-19. So when we talk about general care of COVID-19, this is just, I just want to highlight some of the important points that we have based on our updated guideline in August. So for the general care of COVID-19, for symptomatic treatment, so we use antipyretics, nutritional supports, and also to maintain the fluids and also electrolyte balance. So for example, bronchodilators, we have to avoid nebulizers because it would generate aerosols, to the deep lung. The size is about 1 to 5 micrometers. So we have to be careful to actually prevent the spread of COVID-19. And antibiotics will only be considered when patients have the co-infections with bacterial illness. And of course, we have to do monitorings. We have to monitor all the vital signs in the patients and also to monitor the progressions of the clinical stage of the patients. Okay, so this is the specific treatment. I will not go into detail, but I just want to highlight some of the important points. As everyone knows, category 1, perhaps no treatment is required. And category 2, we have the supportive and symptomatic therapy. And we also have to monitor for warning sign in case patient proceed to category 3. So this is some of the medication you can see here that's been recommended. Also for category 4A, whereby it requires nasoprom and whereby IV DEXA is being recommended until patients got the improvement and it then move to the oral regimen. And for category 4B, and also or 5A, so IV methylprednisolone is still being recommended and then step down to DEXA once the clinical condition improve. And for category 5B is the same thing. We also still use IV methylprednisolone and also tone down to DEXA. So once there is a clinical improvement, just to share with everyone. So I'm going to share next is a few studies regarding pharmaceutical care on COVID-19. So the first one is identifying the side effects of commonly used drugs in the treatment of COVID-19. So in this study, basically they use the computer-based drug-drug interaction. So how they do it is through the graph convolutional network, whereby we have the input and we put it through the graph convolution, and then there is a generate an output of the true drugs that interacts, and also what are the cause of the interactions. So I will show in the next few slides what are the examples of these interaction. So basically for these studies, they engage 8 commonly used drugs in COVID-19 patients, and they look at the interactions with other common 645 different drugs that could potentially cause adverse effects. So they found that hematopoietic and also cardiovascular system, these are the 2 most common systems that being affected from the outcome of drug interaction. So in terms of drugs, heparin and also atazanavir is found to cause more adverse effects than other drugs. So what we can see here is multiple drug usage. So when the patients have polypharmacy, especially in elderly patients, they are more susceptible to have this polypharmacy and therefore enhance in terms of the side effects. So what we can do is we could actually facilitate the selections of drugs, and this could then increase the successful of the COVID-19 treatment. So we can see just now ADR is one of the main part of the drug related problem. Yeah? So by elevating this, so this we can do our part to improve the quality of life of our patient. Okay, so we can see here, among all the 8 drugs most commonly used in COVID-19, atazanavir and also heparin is the two drugs that is commonly encountered with the adverse effects. Yeah, you can see here, and cardiovascular and hematopoietic system is the 2 most common system is being affected by the drug-drug interaction. And this is the example of drugs, for example, like heparin. Yeah, so heparin this is the most common drugs that being interacted with heparin and the adverse effects that's caused by heparins. And we can see heparin also, this is the number of drugs, yeah, the number of drugs. There's a quite number of drugs that could interact with heparin that could actually lead to the, for example, cardiovascular collapse. Yeah? So from here, we can see there's a lot of drugs interact with heparin. Yeah? Heparins be used in thromboprophylaxis in patients that have high risk to get venous thromboembolism or VTE. So this is example for atazanavir, and you can see here, these are the few drugs that could cause interactions with atazanavir. Yeah? And we can see also there's a lot of drugs that could interact with atazanavir and cause, for example, HIV disease. Yeah. So from here, we can get some ideas, and this could be an option when we want to actually select which is the most suitable medication for our patient. From hospital pharmacies in Malaysia, we have some experience during COVID-19 whereby some of our patients, the prescribed medications are not readily available in our formulary. So what we do is we contact the family members as soon as possible so that we know exactly what medications patients are taking all the while. Yeah, and of course, under antiviral stewardship, this is what the development that we developed the local treatment protocol and repurpose antivirals. Yeah. And of course, we also involved with the clinical trials, such as the solidarity trials by WHO. And during the crisis, we are very much into the remote clinical pharmacy services, yeah, to sustain our pharmaceutical care to our patients. So what we do is we do a pairing system, clinical pharmacies, one at work, another one work from home, so that we, communicate with each other to ensure a proper passing, and also still not actually denying the impact of pharmaceutical care to our patient. And a lot of telepharmacies being engaged at this point of time, whereby the medication-related intervention, we communicate through the phone, and also for the history taking, we also do it through telepharmacy. And of course, when we also counsel the patient, we give patient instructional videos, for example, or the medical device counseling. So we send to patient smartphone, and pharmacists will then later follow up with the patient to see whether there's any further clarification needed by the patient. So we also look at the studies because I believe that pharmacists is not only involved in pharmacological treatment, but as a general pharmaceutical care providers, we also look at the non-pharmacological treatment. So this is one of those study conducted whereby we assess in a group of patients with hypertension what are the main factors that involve or attributed the control of the hypertension in this patient. So in this particular study, we found that patients with the youngest age group, around 18 to 39 years, with the lowest income group, unemployed and unmarried individual had significantly high impact score towards the COVID-19 pandemic. Yeah, so this is some of the intervention that we can see to work together with the government, how we as a pharmacist could potentially be together and overcome this problem. during the pandemic. So next one, there's a study basically in the Northern Ireland looking at the impact of the inclusion of clinical pharmacists in the rehab as well as the recovery clinic for patient discharge following COVID-19 critical illness. So basically, they actually enroll this patient in the rehab and also a recovery program, and whereby clinical pharmacists carry out a structured medicine optimization review and identify medication-related problem. Yeah, so they are doing this based on the EDON criteria. This is the criteria based on the level of intervention by the pharmacist. So from here, they found that not only the role of clinical pharmacists is useful, but also there is a potential cost saving there. Yeah, so what we can say is that the impact of intervention of clinical pharmacists is very significant. Yeah.
Excuse me, Dr. Hashniza.
Yes.
You have 3 minutes left for the presentation. Thank you.
Right. Thank you. So we also do a lot in Thailand. They actually do telemonitoring. So there's a lot of things we can do in telemonitoring. For example, therapeutic drug monitoring, drug dosing consultation. Example, they actually do telepharmacy on the CRRT patient. So and also for obese patient, example like we wouldn't know much about the background of the drugs used in COVID-19, whether it affects the pharmacokinetics in obese patient. But what they found of one intervention is that one obese patient, when they use the standard drugs, they actually achieve the same clinical outcome. Yeah, so this is some of the examples of drug-related problems in patients with COVID-19. Yeah, and also patients on extracorporeal membrane oxygenation, whereby they have problems with reperfusion from the heart as well as from the lung. Yeah, so this is some interventions that pharmacists can do, and also patients on hemoabsorptions, whereby this is where we remove the cytokines in patients with SIRS or severe inflammatory response syndrome. Yeah? So there's a lot of, I think, a lot of role that we can play here. Yeah. So this is also to share one of the study in Saudi Arabia, whereby interventions of pharmacists in a critically ill patient. So they found that the role of pharmacists in the ICU become extremely crucial, whereby most of the intervention you can see here were antibiotics, electrolytes, minerals, and vitamins. Yeah. It is not the main one, but this is the adjunct therapy. So finally, I think this is the most important one that people often, overlook or miss. I think the power of counseling and also knowledge dissemination is very important as a pharmacist. So I think there's a lot has been known, like, when we want to counsel patient have to understand the disease itself. We have to make the patients understand the pathophysiology of the disease. How does it occur? Where's the symptom arise? How it is spread? So this is important for the patient to understand and then know how to prevent this contagious disease. Yeah. And what I want to highlight more is the hygiene. Basically, it's not only hand respiratory, but the vicinity, the areas whereby the patient live or working, it's very important. Actually, by this way, we can actually curb this pandemic. Yeah, because I believe the vicinity, especially, is very important for us to help how pharmacists can help to spread the disease. Yeah, and of course, vaccination, this is our main role, that we could actually give more education to our patients on vaccinations, and also the impact, the post-counseling and also pre-counseling medication. And not forgetting, we are busy with the management of COVID-19, but we also have to bear in mind we have a lot of patients coming with chronic diseases that could also impact their quality of life. So this is where we can also find a role as a clinical pharmacist, providing pharmaceutical care on how we could actually manage patients' chronic diseases, optimize the medication use in patients with chronic disease. yeah, for the interest of time. So I think that's all my presentation today. Okay, thank you so much. Thank you so much.
Okay, thank you, Dr. Hashniza, for the nice presentation regarding pharmacist's role during the COVID-19 pandemic. Okay, now we proceed to the discussion session. I will read the question from the Q&A box. There's some of the question already dropped in the question and A box. This is the question from Ms. Hesti Utami. Have you assessed the effectiveness of remote clinical pharmacy services undertaken during COVID-19? What finding have you uncovered regarding the effectiveness of the remote service by clinical pharmacists? I think some of the results you already mentioned before in the slide.
Yes.
But maybe you can give the additional.
Yeah, thank you so much.
Answer.
So actually during COVID-19, this is the first time whereby pharmacists actually seriously ventured into telepharmacies and also remote counseling. So we actually at the beginning stage, but we can see there's a lots of area that we can improve. But of course, there's something promising, yeah, because in this way we could actually minimize a lot of energy, minimize there's a lot of resources at this time. So we actually encounter something new. And in terms of effectiveness, of course, after, for example, when we give video to the patients for the device counseling or whatnot, we definitely have to follow up with the patient to see whether they understand and there is further clarification. So I would say the effectiveness is promising, but of course still need more intervention from clinical pharmacy. Thank you.
Thank you. So you already doing the research about the effectiveness of the clinical pharmacist remote service, but still need further search, still need further finding.
Yes.
Okay. For the next question from Miss Siti Ma'rufah. Thank you. Very interesting presentation about clinical pharmacies. Could you share about community pharmacies in Malaysia during COVID-19? In the community, maybe not in a hospital, but in the community.
Thank you for the interesting question. Yeah, of course, when we talk about clinical pharmacy, not forgettable, our community pharmacy is also providing clinical care to our patients. So there's a lot of role actually in clinical pharmacies, for example, more to counseling when patients come to to community pharmacy. Example, the techniques of using the mask, the donning of the mask is also very important. So that is also one of the area whereby community pharmacy, play an important role. So besides that is the more towards counseling, for example, like disinfection techniques, for example, like sterilization techniques, sanitization techniques, and of course, simple like the common counseling on drugs, symptomatic treatment for COVID-19 and so on, antipyretics and the general health of the patient. For example, how to increase the immune system of a patient or even public during COVID-19. So the use of vitamin supplement, this is definitely increasing in the community pharmacy perspective. So there's a lot of interest on different types of supplements, yeah. Not only vitamin C, but there's a lot of supplement, yeah. For example, a lot of supplements that could actually act as an antioxidant, and in that way we could also boost up the immune system of the public and also patient. And of course the general counseling on the chronic medication and so on. So community pharmacy also involved in the vaccination program as a volunteer, so on and so forth. So there's also a lot of huge potential of community pharmacy during COVID-19, not only hospital, but also community pharmacy.
Okay, thank you, Dr. Hashniza, for the nice answer. Also, there is a lot of role for the community pharmacy as well. we mostly in the education to the community regarding the how to disinfect, and then the vaccination to ensure that all the people in Malaysia get the vaccination. Okay, is there still have time for the Q&A? Maybe there's one more question. Oh, I think the time is up. Okay, sorry, Dr. Hashniza, for the tight schedule. We finish our discussion session. But before we end the second part of the today plenary session, on the behalf of the committee, we will deliver the certificate of appreciation to Dr. Hashniza. Thank you once again, thank you for the nice presentation. Okay, this is the end of plenary session. Once again, I want to extend our highest appreciation to the speaker for the insight and inspiring presentation.
Thank you very much.
Dr. Son already left, so thank you, Dr. Hashniza.
Yeah, thank you so much.
Okay, hopefully we can see you again, not far in the future. Okay, thank you.
Thank you so much.
As a moderator, I do apologize for the inconvenience and mistake during the today plenary session. And once again, thank you, Dr. Hashniza. Thank you very much for the attention and participation. And I'll return it to the Ms. Hasna as an MC.
Yes, thank you very much to the organizing committee. Bye. See everyone again.
Thank you, Dr.
Bye.
Hashniza. Okay.
Thank you so much for our both amazing guest speakers and our moderator. Now we move on to the oral presentation session. The oral presentation session will be held in different room